Hello, everyone, and welcome. My name is Corey Thornton. I'm the Managing Editor for Market Intelligence at Open Minds. Today, as part of our weekly Executive Web Forum series, Open Minds Senior Associate Sharon Hicks will discuss process reengineering in behavioral healthcare. Ms. Hicks has extensive experience in the health and human services field, including health plan management, clinical operations management, and technology. Before we get started, we have a couple of housekeeping reminders. Your audio will be muted during today's briefing, but we also rely on your questions and comments via the question box on the right-hand side of your screen. You can send those questions in throughout the briefing, and Ms. Hicks will answer them. The slides and recordings from today's briefing will also be available on the Open Minds website starting tomorrow. And with that, Sharon Hicks.
Hi, everybody. Thank you for spending some of your Thursday afternoon with us. I'm going to talk a little bit about process reengineering, sometimes called business process reengineering, specifically in healthcare and behavioral healthcare, but I'm also going to talk about why it is a strategy that needs a little bit of tweaking to really work on the healthcare side. So our agenda today is we're going to define what process reengineering is. We're going to describe a process improvement model that has been used in healthcare. We're going to talk a little bit about why perfect is the enemy of getting better. And we're going to discuss how business process reengineering models can empower your staff to solve problems on their own. I'm going to stop every 15 minutes or so and ask for questions, so I do encourage you to write any questions that you have down, and Corey will read them and we can discuss. So people use business process reengineering and continuous quality improvement interchangeably, but they actually are different things. So continuous quality improvement, or CQI, is an ongoing, never-ending process. It cycles and then immediately starts again. Whereas business process reengineering really ends when the objectives of the project are met. There's a relationship, because once you've re-engineered a process and you feel comfortable with it, it can turn into an ongoing CQI initiative. So when do you use which strategy? So business process reengineering is a business management strategy that focuses on analysis and design of specific workflows. And it's really designed to help an organization break apart to its smallest level all the steps that go into a full task and think through the value and the actions and the details associated with each of those tasks. So it helps people restructure organizations by getting into the minutia associated with a business process. And it has to be focused on business objectives. It has to be focused on a clear outcome. And I think that one of the things that people do is they take a small piece of a process and they re-engineer that so it's within their department, but it doesn't actually change anything from a big picture standpoint because it's not optimizing each sub-process. It's just looking at the sub-processes as if they're not interrelated. So the steps in business process reengineering are, there's, as many models of business process reengineering as there are, different types of popcorn. So you have to take a look at what it is you're trying to do and what resources you have. If you pick a model that is very labor intensive or requires a significant amount of statistical work, then you have to have the resources to support that. So, but they all have the same kind of general basic steps, which are you define the objective, you study the existing process, you formulate a redesign plan, you figure out how you're going to measure whether or not that plan works, you implement it, and then you measure the outcomes. You can repeat again if your outcomes that you get are not what you expected or hoped to get. At some point, when you've achieved your objectives, if it's a major workflow or major indicator for your company, you may switch it into a CQI initiative. And then there are probably more BPR programs that have failed than have succeeded, especially in healthcare. There's a lot of reasons for that, and I want to talk through some of those today. People try to make something slightly better instead of changing it, and so nobody really takes a step back and looks at the actual magnitude of the problem. So minimizing the problem and then fixing one piece of it is definitely a reason for suboptimal outcomes. Failure to be able to properly take the process apart and define them. Ending the process before it's completed because there's frustration with slow progress or because people on the team are not working well together. The team placing constraints on the definition of the problem and bypassing what senior leadership is looking at, or the corporate culture is not in line with the construct of what it is you're trying to do with the full process. And then number 6, which is probably the most frequent reason that things fail, so I should have put it as number 1. Inadequate resources are allocated by the company. Business process reengineering is not a small effort, it's a large effort. So to do it well, you really need to make sure that you're allocating the right number of resources and that you are identifying this as someone's job for a specific period of time. So they're not trying to do their regular job and then do this as well. So other reasons, team trying to do too much at once, which is what I just talked about. Reengineering is not given its own resources. Senior management is not willing to own the corporate level impediments to implementation. Trying to keep everybody happy. So if you've ever written a policy and you've tried to write the policy by committee and you have one person who says, I don't think we should use that word because that word has negative connotations. So let's use this word instead. And before you know it, you have this, very broad-based policy that everyone is kind of okay with. When you read it in detail, it doesn't really say anything. And so that's another reason that these business process reengineering programs can fail, because everybody feels like their view is the right view, and whoever's leading the team tries to get consensus as opposed to trying to keep everyone focused on the end result. And that's really a huge one. And it ties into number 5, which is, what is the end result? If the project's not well defined, then no one knows how to get there. And then the final piece is a need to have other groups involved. So if you think of a process, it has potentially a beginning, a middle, and an end. Everybody who touches it during that entire cycle of the process needs to be involved if you're going to re-engineer the process. You can't just pick out one piece and re-engineer that, because it's not going to work. So when do you use BPR versus when do you use CQI? And there is some good information available out there. You use business process reengineering when there's a need to redo an existing process or create a new process. And what that means is that you can identify the process. So let's say the process is obtaining insurance information from brand new patients that you've never registered before. There's a beginning, you identify the patient. There's the middle, where you gather the information and check for completeness. And then there's the end, where you put that information into whatever your master patient management number system is, and you create them as a fully created, all the information that you need is there, and the person has a patient number. So that's a process. You can't not focus on the beginning, the middle, and the end. You have to look at the whole thing, and you can tell when that process ends. So that's really when you want to use BPR. You want to use BPR because you're either creating a new process or there's an existing process where there's lots of errors that occur throughout the process. And you need more than just incremental improvement, right? So it's not, Jane in registration always forgets to put in people's middle names. And so middle initials are really important to us because we have, 80,000 people in our master patient index. And so there could be lots of Sharon Hickses, and we want to know which Sharon Hicks we're talking to, right? So that you talk to Janie and, she starts asking that question, right? So that's kind of incremental improvement. And so the final indicator for BPR versus CQI is when the process is cross-departmental. So even in this context, think about this patient registration example. Someone has scheduled the patient to come in. Someone will be taking the patient afterwards. Someone is using all the information that you've put into the master patient index to be able to create bills, post cash to people's accounts. Medical records needs that information to be able to create medical records. So it has lots of cross-departmental components to it, and it has significant inputs and outputs. You use CQI when you have a process that you want to make incrementally better. So the process is kind of working, but you wish people would do it a little bit faster. So now you can use a CQI model, which looks very much like BPI, right? This is where I think it's a little different. BPR has like these steps and it's a cycle and it can continue, and CQI has these steps and it's a cycle and it could continue. So people use this interchangeably, but it's really, they really are different methodologies. So CQI is you want to refine a process, you want to instill a quality focus in a department or in a series of processes. You know that the improvement is going to be incremental rather than brand new or, a change of 50% or 100%. And the process is mostly contained within one department. So let me stop before I get into the life cycle management. Let me stop and see if there are any questions.
Sorry about that. My camera was not coming on very quickly. We do have one question, Sharon, this one from Emily. How important is it to have a good IT support department and data use during this process at the early stages?
Yeah, so that's a great question. The reality is that business process reengineering, when you read articles about it and when you read, case studies, is almost always focused in IT. So there's a huge component of this that is data collection, data analysis, pre and post analytics. I think it's less that your IT department is involved and more that your data analytics or quality department is involved. You need people who are going to be able to quantify whether or not your process has been successful. And what does that mean is really one of those questions that come from your analytics department, and how you're going to measure it and what methodology you're going to use and what statistical tests you're going to use. Those really become more important than having someone from IT at the table, but IT is usually a stakeholder in this because the data collection component can get pretty detailed. So let's go on to the life cycle management. The first step in business process reengineering is to ensure that the resources are available to support the project. So what are you focused on? Who's on the team? And get that meeting scheduled and appoint a person to organize documentation. Now, this final get a person to organize documentation sounds like it's really simple, maybe a no-brainer. It is absolutely not. Probably one of the hardest efforts of business process reengineering is that you need somebody who's 100% dedicated to all of the administrative tasks, all of the communication between the different parts of the team, all the documentation, making sure that every decision is outlined in incredible detail, making sure that all the conversations about the consequences of moving in one direction versus another direction are documented. And so this planning and organization component is usually a person's full-time job for the duration of the reengineering project. Next is the business rationale. So how do you express to the people who are managing the resources that what you have is a process that is so integral to the success of your organization that you need to take resources from existing parts of the program and put it towards this? And then defining the solution, which again sounds really easy, and it is absolutely not easy, because you have to think about writing it in such a way that you're going to be able to quantify an answer and not qualify an answer. And we'll talk a little bit about that question, how to write that question a little later on. And then determining measures of success, which absolutely goes along with how do you state what your goal is. So that's step 2. Step 3 is understand what would happen if we did nothing. Because oftentimes people jump into business process reengineering because they read about it online, or it sounds really cool. Not cool in the sense of anything actually cool, but cool in the sense that, you know, all the articles you're reading about it make it sound like it's the right thing to do. So what happens if you don't do it? That is one of the most important questions. If the answer is, if we didn't fix this, not much would happen, then it's probably not the right problem statement to be attended to via a business process reengineering cycle. Because those programs are expensive, because those programs require a lot of resources, make sure it's something where you're going to get a big bang for the buck. And then you have to start segmenting out and deconstructing the current process with a mind towards redesign of each segment, trying to really understand all the moving parts within each segment. And this is where your documentation person really shines if you have a good one, because when you finally put the whole thing down on paper, you're going to be amazed at how big it is. And then obviously this last step is, the 4th step is very important, because you need to understand how you're going to measure what you're going to measure. So this is where the IT component, the question that Corey asked, is really critical. How are you going to determine your success? How are you going to measure what you've done? So when you're asking that question, when you're setting things up, you really have to be thinking about data collection, data analytics, and data measurement. And this is where, again, it might be in your IT department, it might be in your quality department, it might be in your data informatics, decision support department, but you need a group of people who are really expert in measurement and evaluation. And then you have to design and create performance reports that truly answer the question of whether or not this is improved. You're going to do that at the beginning when you're taking your baseline. If you can use the exact same reports at the end as you used at the beginning, that's a good indicator that you had an appropriately defined business process reengineering effort. And then when it's all done and you've gotten where you want to go, you want to continue to refine it, you want to continue to make it good. And so you're going to move the business process reengineering project into your ongoing quality improvement life cycle. We stop here again and ask if there are any questions, and we can go on to some descriptors of actual BPR processes that have happened in healthcare.
Yes, Sharon, thank you. What is your advice for adopting and investing in a data dashboard for this information?
Yeah, so that's a great question. Data dashboards can take the place, whoops, let me go the other way. Data dashboards can take the place of this creating performance reports. So do you need a way to review data in a consistent fashion? Absolutely. Does it have to be through a shared dashboard that's served out through your company's intranet that has, SPSS or SAS behind it, that has the ability to drill down and get graphs? It's wonderful if you have that, but it's not actually required. It just makes the final reporting easier if you have that. It makes the management of it easier. It makes it easier to make the decision about moving your BPR project into your continuous quality improvement project. But there are ways to do it without the fancy tools, regardless of whether you have a beautiful dashboard that, again, is interactive and parameterized. You absolutely 100% need reports. So you can do it inexpensively, but you can't do it without data. Let's talk a little bit about the process improvement model that can be used in healthcare delivery. And healthcare delivery is really tough. We'll talk about that now, actually. So the high level example is, can I state my objective, right? So I went into Google Maps and I Googled directions from LaGuardia Airport to San Francisco Airport. And what I get back is that there are two routes. One is 44 hours, one is 43 hours, and it takes me across the top of the country. So now I can pick a route. However, now there's details, right? I can't drive whatever that was, 44 hours straight. So I have to figure out where I'm going to stop. So now I have to pick the places where I'm going to stop. And every one of these circles is a place that's about 8 hours apart. And so now all of a sudden I've added 6 full hours to my process because I've built in these stops, even though they're on the way. That added a total of 6 hours. And then how do I know that I'm there? Well, all I said was I want to go from LaGuardia to San Francisco Airport. So I guess once I see a sign that says San Francisco Airport. But what if that's not actually the question? What if that is not actually where I want to go? So this is the difficulty with healthcare. It is not a difficulty with manufacturing. Manufacturing is where business process reengineering, Six Sigma, all those kinds of things grew out of. And it makes perfect sense. Six Sigma means that it's a math term, and it means that your likelihood of something happening is 99.996666. So 6 numbers after the decimal point. That's your likelihood of the process working exactly the same. So 99.996666, I think that's 6. That's what 6 sigma is. So 1 sigma is 99.9%. So what in healthcare happens at a rate of 99.9%? Not a lot, right? You can say every child should get this vaccine. But the reality is that there's lots of variables. Some kids are ill and they can't get the vaccine. Some kids have parents who don't believe in vaccines, so they don't get the vaccine. Some kids, can't tolerate the vaccine at the specific age, so it happens later. It is absolutely not at a rate of 99%. Everybody should go get a checkup at least once every 2 years. That's not at a rate of 99%. So, and certainly not 99.9%. So it makes a lot of sense when you're talking about a process that you're redesigning, where the process is something that should be repeatable to a Six Sigma level. But in healthcare, we're happy if we get to 92%. We're happy if we get to 95%. We never get to 100%. Well, maybe we do, so don't quote me, but we mostly don't. And it's partially because we don't have the kinds of questions that you have in engineering, right? In engineering and manufacturing, I am making this bolt that keeps the wing on an airplane. And I want that bolt to be manufactured to a Six Sigma level. And I'll know that it happens because I'm going to check every piece of the process and I'm going to check the end result, which is the bolt. And it's really important because we don't want 0.1% of our plane wings to fall off. That would not be okay. So we want to engineer to that incredibly high level. But for this example, I could say, I want to go across country. I want to end up in San Francisco. I want to move from New York to the West. I want to drive across Interstate 80. I want to drive about 8 hours per day, or I just want to get the hell out of New York. And all of these questions are valid questions to demonstrate the solution that you see in front of you, which is I'm going to get in a car in New York and I'm going to drive across Route 80. I'm going to stop at these various places and I'm going to end up in San Francisco. It's not really measurable because I don't know what question I'm asking. And so we get into this problem that we have with doing business process reengineering in healthcare. I want my consumers to have a more positive experience. I want consumers to give us good ratings for satisfaction. I want consumers to be happy. I want staff to care about whether consumers have had a good experience. I want to be a top-rated clinic. Those are really non-measurable. I worked for an organization that was very concerned about the fact that its patient satisfaction scores weren't very high. So what it did was it told the physicians that if their individual patient satisfaction scores weren't high, the physicians were going to be in big trouble. Maybe it was even going to color their performance appraisal. So in other words, what they said is, you have to be nicer to patients or we're going to be really mean to you. That's probably not a successful strategy of reengineering, and it's actually not reengineering at all, but it's a great example of where not taking a systemic view of an issue is very unlikely to meet individual results or to net individual results. So some measurable examples are consumer satisfaction scores are going to rise to 92%. Consumers will get appointments within 24 hours of first contact 95% of the time. We're going to give people a standardized assessment at the beginning of treatment, at the end of treatment, and there's going to be a statistically significant improvement based on those scores by the end of treatment. We're going to answer the phone live 98% of the time. Now, whether those are parts of a process or the whole process is related to how you define the process that's being engineered. And just having that component of it gets to the sense of why doing this in healthcare is sometimes so complex. So the primary questions that cause difficulty: is the result repeatable? Could you do it again? Healthcare processes are difficult. Few of them can be done 100% of the time. There are processes, I'm now going to disagree with myself, there are processes that have to happen 100% of the time, right? And Atul Gawande wrote an amazing book called Checklist Manifesto that has a really good discussion about those processes. So he was a surgeon, is a surgeon, and he went through the what happens pre-surgery, what happens during surgery, and what happens after surgery. So should your surgeon wash their hands 100% of the time before doing surgery? Yes, absolutely. Should everyone in the operating theater go through a complete decontamination process before they go into the operating theater? Yes, absolutely. So the Checklist Manifesto really talked about how It's the small things that people do so often that they forget if they did them already, that when you're following a checklist, you don't forget. So as an example, I had a procedure that required anesthesia 5 different times. Once by the nurse who put in my IV, once by the anesthesiologist, once by the nurse anesthetist, once by the doctor doing the procedure, and finally the orderly who wheeled me into the procedure room, all asked if I had any bridge work or dentures that could come loose while I was out. The reason they asked this was because if something happened and they had to intubate me and I had a bridge, they were going to have to remove that bridge or they might kill me. So I was asked 5 times because every single person knew that that was on their checklist to do. That process has probably had a lot of reengineering associated with it. But again, it's med-surg, so it's a little easier to come up with what are those things that should be never events. Never should you try to intubate someone and have their dentures get stuck in their windpipe. Like that should never happen, right? So clearly someone had done a whole bunch of engineering around that particular process. In behavioral health, there are fewer of those kinds of examples. And so I think it's where we struggle a little bit when we start talking about business process reengineering. We stop there and see if there are any other questions, and then we can go on to the last couple of sections.
Absolutely. Thanks, Sharon. We have a question. What do you do when someone on the team doesn't agree with the destination and will not cooperate?
Great question, and it's actually probably my next slide. So it's not. It's my next slide in the next section, but that's okay. I'll answer it now. Who you pick on your team is critically important. And actually, let me wait till the next section to fully answer it. But the short answer is you remove them from the team, which is something that culturally a lot of us have issues with. And again, I'll talk about that in a second. But it's really critical to have that empowered team to be able to make sure that you have consensus on what it is you're working toward and that you need to solve the problem. And so one of the things that kills us, especially in we're behavioral health folks, we want to do things by everyone feeling good about them. We want to talk about how we all feel. We want to make sure no one feels bad. Oftentimes that team dynamic is what gums up the works. And I'll get into that a little bit more in the next section. So you can't have re-engineering without engineering, right? This is what I was just talking about. Generally true business process re-engineering is workflow, design, technology, measurement systems, and a lot of higher math, as we were talking about the Six Sigma test. But in much of healthcare, the response to the question is what causes the action and not the question itself. So often in behavioral health, we go through a BPR process, but we don't deem it successful. So this gets back to the section we were just talking about, which is how do you define success? How do I know I've arrived? Is it because I see the sign for San Francisco Airport? Where am I staying? How am I unpacking my car? I've been driving for 8 hours. Do I what? I park at SFO and go to the bathroom? Like, what happens at the end? It can't just drop off like, okay, now I'm at the airport in San Francisco, so what? So we have to figure out how we define success. And therefore, when you read scholarly articles of successful business process reengineering experiences in healthcare, you find things like cleaning the OR after use, scheduling and timing of pharma deliveries to inpatient units, clean linen delivery to a unit, or the supply chain component of the unit. And that's generally not what we're talking about in behavioral health. So what if we take some of the good principles of BPR, but we do it more flexibly? What if instead of striving for consensus, we create the vision that leadership espouses and it's shared? What if we focus on incremental shifts? What if we empower staff to solve problems And what if we anticipate situations where the new process is not going to work, or where the staff is empowered to have flexibility to broaden what the new process is? Because unlike manufacturing bolts to keep the wings on an airplane, you don't really want your healthcare delivery staff to say, I'm sorry, I could save your life, but I'm not allowed to because it's not in my job description. So we need to figure out how to build flexibility into the design, into the redesign, into the processes that we develop. So as a kind of summary of what we just talked about, the best principles of business process reengineering require that we agree on a destination, that we know how we're gonna know if we got to the destination, to build a team that's actually gonna work together to get you to that destination, to create iteration that allows you to learn from problem solving along the way, to create or change the culture from a blaming culture into a problem-solving culture. And this one is, I think, an interesting one, which is cultivating the correct approach to determine if a problem is big or small. Oftentimes, what happens is people get derailed by, but I once, by some anecdotal comment, like you're talking about, asking the person at the end of the call whether or not they're satisfied, right? So that becomes a conversation. Now we want to ask the person before we hang up, were you satisfied? Is there anything else I could do to help? And someone says, yeah, but I once was talking on the phone to someone who said, stop asking me all these questions. I don't want you to ask me any more questions. I'll tell you what I want. You'll tell me yes or no, and then I'm going to hang up. So if I ask them if I satisfy them, I think they'd be mad. And then you get into this whole conversation about, well, maybe you shouldn't ask that question all the time, because anecdotally, one person once had an experience 5 years ago that something happened. And so the reality of it is that we know people are not machines, and we know that 100% of the time doing something exactly the same way is not going to work for all people. So how do you figure out if it's a big problem or a small problem? And if it's a small problem, how do you say to the team, let it go? Yes, that's going to happen. Doesn't matter. Let it go. And so this is where I'll get into the section about the staff and the staff personalities. I don't know if there's any other questions before I move on to that, but I will answer the last question first.
Hey, Sharon, this is Meena. Based on the great summary you just showed in your slide, my question is how, I guess this is what you've been talking about throughout, but just sort of want to ask once again, how do you determine if something escalates to the need for business process reengineering or even continuous quality improvement versus it being some other kind of a problem? Is it just that I need to, address a staff person's issues? Do I need to put somebody else on the job? Do I need to do something else? But what are the red flags that tell me I better stop and look at the process?
So I think it's something I said earlier on, which is the process reengineering indicator includes the construct that the process has lots of stakeholders at the beginning, the middle, and the end. So going back to my registration issue, right? Someone comes in, they're a new patient, haven't been registered, they don't have a number in the master patient index, and I'm a big organization. I have, hundreds of thousands of people in my master patient index. So the registration piece seems like it's limited to the group of people who do registration or admissions, but it's not. It has stakeholders everywhere. Stakeholders are clinical, stakeholders are medical records, stakeholders are the billing department, stakeholders are the quality department. So everybody needs that information to be pristine. So I can say my business process reengineering project is around assuring that all the information that's needed for all those other stakeholders gets attended to in the new process. If it's something that only affects a small group or one department, generally then it's not a business process reengineering project. It's a quality improvement project within that department. So the big indicator is how many stakeholders inside and outside of that department are using the process or the output from the process. Does that help?
It does. Thank you very much.
So let's get into the culture conversation, which I think is one we all are very familiar with in behavioral health, because we are all people who like to talk. We are all people who understand the value of clear communication, and we maybe communicate a little more than we should. It can be the people who've been around this the longest. So people say, well, we've always done it this way. We do it because it's our culture. Why would we want to change that? There's no reason to change it. So let's just leave it the way it is. It could be the person who's the loudest voice in the room. I'm the charge nurse, and that's why we're going to do it that way because I say so. And it may be leadership. People not feeling confident solving problems on their own, waiting for the boss to weigh in, and department leaders or section leaders not feeling comfortable being able to name a problem. And we've all had those experiences. I worked for somebody who, if you came to her with a problem, she would yell at you. So there was no incentive to surface a problem. In fact, people would try very hard to kind of put Band-Aids on problems so they didn't have to surface it to her, because no one wanted to get yelled at. So really understanding who gets to solve those problems in your organization. And this begins to answer the questions about the team. You have to give people the authority to disagree with each other. So if you have a boss who says, I'm not leaving until everybody says they're happy with us, then you basically solve all the problems by negotiation. And what happens in negotiation is that as soon as you agree to negotiate, you've decided that you can give up some things, right? That's the context of negotiation. So if every problem-solving initiative is a negotiation, it means that we're agreeing at the beginning that there is no set destination. So I want to say that again. So I disagree that we need to manufacture the bolts to the 6 Sigma level, because of the cost of going from 4 Sigma to 6 Sigma is the cost it was to go from 0 to 4 Sigma. And I say it's just not worth it. Those last 2 percentage point, it's really not percentage points, it's 0.0001 percentage points, but that last component isn't worth financially getting there. And you'll have people who will say that, right? They'll say it's not worth the expense to get to the 100% because it costs as much to get the last couple of fixes in. And if you're doing that, you're negotiating. You're saying, okay, it's okay. I'm going to give a little on this standard that we created that said that the bolts have to be manufactured to a 6 Sigma level. As soon as I agree to negotiate, I've decided that I can give into some of my requirements. Can I negotiate on 100% of people coming into my operating theater should have washed their hands, disinfected, and put on clean scrubs? No. Can't negotiate on that. So there has to be something that you feel comfortable enough expressing your leadership on. And it's not that everything has to be done by one person. It's that you have to understand the difference between things that could be negotiated and things that can't be negotiated. So in this context of a boss who requires everyone's happy, let's say we're talking about a practice in an emergency room where the psychiatrist doesn't want to admit people to a unit when the charge nurse on the unit says that the milieu is a little crazy. And the charge nurse in the emergency room says, look, I need to get these people out of the emergency room. So yes, I understand that the unit is a little crazy, but we got to get these people out of the ER because they're at higher risk in the ER for hurting themselves. So the Reengineering project is about how to make sure we're getting people out of the emergency room as quickly as possible. If the leadership on the committee, leadership on the project team says, no, the unit's right, we have to make sure we've attended to the unit milieu, then in fact, the whole point of the program, which is getting people through the ER, is invalid because the leadership at the highest level is saying, I don't agree that that's where we're going. So you have to make sure that people have the authority to disagree with each other, and you have to make sure that there is a stated end result, and that if people on the team disagree with that end result, that they can get removed from the team. So when you have somebody who says, I don't want to change this because we've always done it this way, or I'm in charge because I say so, or I'm nervous that the boss is going to get mad at me, those are not people that you necessarily want on your business process reengineering team, because you have to cut through all the noise. You need to empower people to cut through that noise. So you have to give them the power to advocate on behalf of the project, the clients, the customers. The thing that people report is the hardest for them is when it's going to cause more work for their colleagues because they feel guilty. So they'll say, yes, it is hard to get someone up to the unit. Yes, I understand how hard it is for the charge nurse when a new patient gets admitted and the new patient, has aggression and the milieu is already a little difficult. And now we're bringing someone up there. And then everyone feels really bad. So they're like, all right, let's just let the patient stay for an hour in the ER because I'm worried about this charge nurse. Well, that's an upside down view of what it is you're trying to do. If you're trying to get people in and out of your emergency rooms, it doesn't matter if the unit staff is slightly unhappy. What matters is that you're following your process. And I think that's where in healthcare it becomes very difficult. You will have people arguing that it's okay if 0.02% of wing bolts fail. But most people will not argue that point. Most people will say, that makes me nervous to say that. However, when it comes to healthcare, where we don't have those kind of hard and fast rules, it's a little more simple to say, all right, just this one time, I'm going to let this patient sit in the ER because it's okay. And you have to make sure that the team understands and that the leadership of the team understands that when someone demonstrates that they're incapable of working on that team, you have to move them out. It's very hard. It's not something we're used to doing. We're used to kind of ignoring the people who are not succeeding and kind of working around them. But in business process reengineering, you really can't do that. And so my caveat here is I don't know anything about sports. So sometimes I use sports analogies and they don't make any sense. However, the analogy I'm going to do with I'm going to use in this one is you're the coach. You're as the leader or as corporate leadership, you're the coach. You're not the ace pitcher. You need the team. The business process reengineering team has to be empowered to do the work. So I had a boss who said, people who are A-team players hire A-team players. In other words, if you know you're really smart, you hire really smart people because you don't want to be the smartest person in the room. You know you're smart. You have no worries about whether you're smart or not. So when someone else is in the room and they're smart too, you're like, oh, that's great. It makes everybody smarter, right? So a rising tide lifts all boats. But people who know that they're not that smart often want to hire people to tell them how smart they are. And so they'll hire people who are C and D level players. It's tough, but you can't have B team people leading reengineering processes. You just can't. You have to have people who don't mind being challenged. You have to have people who don't mind not being the smartest person in the room. You have to have a good, solid discussion about strategy and tactics once the defined project scope is is written down. And now I have a couple of examples. So let me stop here, and I'm going to go through these examples relatively quickly. I don't know if we have any more questions or not, but if we do, I'll answer them. If not, I'll just move on.
Thanks, Sharon. We have a question. It's really kind of a two-part question. Everything you've talked about up till now, who normally owns that process at a company versus who should own that process at the company?
Yeah, that's an interesting question. So normally, no one owns it. Oftentimes, it's someone in the operations area, like the chief operating officer. Lots of times, people put reengineering projects in IT. But again, that's really not exactly the right place. So if you have a quality department, it can go there. But it really needs to be, I don't know what the right word is, seeded by or approved by, empowered by someone at the highest level of the organization, like the chief operating officer or the chief quality officer. And usually, if it's put in IT, it ends up being marginalized by the people on the project team who say, well, I don't work in IT, so I don't know what that is. So at the very least, it needs to be in the operations area that it's going to be affected by. Oftentimes people do business process reengineering when they're thinking of building a new information technology infrastructure, buying new software, creating dashboards, and those are all fine. And in that case, it would be somebody like the CIO who would be the executive sponsor. But even with that, it really should be someone who's thinking broadly about the entire structure if you're going to get the best outcome. So let me give you guys just a couple of examples from healthcare. This is from the IOM report, To Err is Human, which found that the majority of medical errors were a result of systemic problems rather than poor performance. And what I mean by that is, so this particular paper took a look at rehospitalization. This slide's a little tough to see, but the bottom here is rehospitalization. So what they did was they broke it into 3 different groups. This was the analysis. They discovered that for all the people who got rehospitalized, readmitted within a certain number of days of discharge, there were 3 factors that went into the readmission. One was the healthcare system, one was the patient, and one was the clinician. So then they went down, what are all the reasons that someone goes into the hospital again? And there were things like on the patient side, they had a new medical problem that came out. They didn't do their post-discharge follow-up that was required. They had problems with understanding the language and the information wasn't printed out in a language that they understood. On the healthcare system side, the discharge summary wasn't sent to the PCP, or the medication error, there was a medication that wasn't covered by their insurance and no one had checked on that. There was no timely follow-up. There was a lapse of, or there was a need for community-based services. For the clinician, who they meant was the PCP, there were lab test errors where things weren't performed. There was an inappropriate discharge where the clinician discharged the patient before they were really medically stable. Or there was a need for community resources, and community resources were not attended to as part of the discharge, right? So this process was one part of a legal page-sized process that went through all the different things that might result in a rehospitalization. So that was step 1 of the business process reengineering. Step 2, that was appointing the team. So making sure specific resources were identified, making sure some team members knew they were assigned to this full time, and then appointing the team and empowering them. And then they did a full process map. So this was everything that could go into whether or not someone was ready for discharge. So here's hospitalization, here's ready for discharge, here's all the things that go into medical, social, behavioral, the physical, the physical therapy, occupational therapy, nutritional issues, preparedness, right? And so this is one little snippet from like a giant process map of every single thing that could happen while someone's in the hospital so that you could answer, are they ready for discharge? And they assigned different teams, and you can kind of see it in the bottom here. They had a B1, B2, B3 team, a B4 team. And so the teams all had different components of this that they had to work through the entire process as much as possible, get into what could happen, what should happen, what did happen. And then they gathered all the information from everybody in a sample who had been rehospitalized. So they found the top reasons for rehospitalization: lack of adequate support after discharge, discharge with too many symptoms that were not controlled, people being non-adherent with medication, people being non-adherent with follow-up, people using substances, people being homeless, people not going back quickly when systems reemerged, and then external events outside of patients' controls. These were the top reasons that people rehospitalized. So then they did analyses, and they did two types of analysis. They did a failure mode and effects analysis, and they did a root cause analysis. And I'm not going to go into exactly what goes into this because you guys can Google them, but basically these are different kinds of analyses that allow you to plot out the reasons that certain things happen, and then allows you to take a look at how predictable they are. And then they made recommendations, and I'm not going to go through all of these, but there were a ton of recommendations, including discharge information in people's languages that they speak, discharge plans reinforced by contacting the hospital team if they were at high risk, you know, really, really, really detailed. This is what we recommend, and if these things are put in place, then we have a very, very, very good chance of decreasing rehospitalization. And then step 7 was move the process into ongoing CQI. So the ongoing CQI was a sample of every rehospitalized patient gets pulled and reviewed, and they figure out which of these 11 things failed to happen, and how do we assure that they happen all the time? And that's CQI. So in the BH specific example, I don't want to rush through this, but you guys will have the slides if you want it. There's a program called Hicks Community Mental Health Center, because I'm so creative, I really know how to make up names. And Hicks Community Mental Health Center has an average wait time of more than 10 days to get new patients assigned to a treatment team. The range is between 6 and 30 days, and their no-show rate is over 40%. So the work group has clinical leadership, call center leadership, quality management, accounting. They do surveys, interviews, and time studies of existing workflow. They find that there's not enough appointment slots, that there's no differentiation in terms of the process that they use for people who are motivated versus people who are non-motivated. There's no contact between the call and the appointment time. So they appoint the team, right? There's the analysis of cause. They appoint the team. They do a process map. How do calls come in? What time of the day? What are the outcomes when an appointment is scheduled, when an appointment's not scheduled? Time of day, day of week, highest volume. What's the process of offering patients an appointment time? What does a no-show patient cost in accounting terms? What's the difference from the shows versus no-shows? Is there a difference? If I interview people who didn't show for their appointment, what is it that they tell me? If I interview clinicians who have patients who no-showed, what do they tell me? And how do I analyze? And then I analyze the relationship between the type of patient and the no-show rates to see if there's any correlation that I can find. And this is where you do have to do some math. And so the review of the data demonstrates that the cost of a no-show is $200 per service. So that's the cost of the telephone staff member, the cost of the call center, the cost of the outpatient clinician expecting that they have an appointment when they don't have an appointment, right? So there's $200. So now that means that if they can fix this problem for $150, then it's worth doing it. So they can spend a little bit of money to fix this problem if they can quantify the number of people who no-show, and they can quantify the expected improvement against that number, then they actually have a little budget to work with. And the top 3 reasons they find is that the crisis ameliorated, the person didn't need care, they just forgot, or they actually ended up going somewhere else where they got an appointment sooner. So their findings then had to do with increasing the appointment times that were available, developing a process where emails were collected so that people got sent links and reminders and they stayed in touch with them in between the appointment time. They figured out a way to determine who's at high risk for no-show, and those people get flagged, and the clinician calls them before their appointments to do short phone engagement sessions. The intake staff get trained in motivational interviewing techniques, and they developed a monetary reward program for outpatient clinicians who are able to engage with patients. The reward is earned when the patient attends at least 8 sessions over the course of 6 months. So they're now putting their money into the engagement and retention of patients, which starts at that intake. And then this is the, standard clinical practice became that the having more slots available decreased no-show rates by 45%. Developing the email address and, touching people in between the appointment time and the actual appointment, that it led to more rescheduling, but the second appointments had a risk of no-show that was 75% lower than the baseline. And then training the staff in motivational interviewing techniques resulted in slightly longer call durations, but decreased no-shows by 20%. And so I think we got to address some of these things, except for question 2, which is, do you recommend using staff or consumer surveys to set improvement goals? You can. It really just depends on what problem you're trying to solve. I think the hardest thing about business process reengineering goes back to that slide where I don't know exactly why I'm driving for 50 hours to San Francisco. Is it because I just want to go to San Francisco Airport? Is it because I want to go cross country on Route 80? Is it because I just want to get out of New York? Is it because I want to, stop in Erie, Pennsylvania? Like, there's so many destinations, there's so many questions that I could answer by that cross country trip. So making sure I understand where I'm trying to go and why I'm doing it this way, that's really the hardest part of business process reengineering. But once you get there, then the rest of it becomes doable. I know we're out of time, so I'm going to stop there. Corey, I'm not sure if there's anything I'm supposed to do at the end here.
Yes, I think that wraps us up. Thank you, Sharon. And I want to thank everybody for joining us today. We would like to remind everyone that the slides and recording for this will be available on the Open Minds website tomorrow. And we will be back next Thursday at 1 p.m. Eastern for the web forum, Assessing and Building Your Organization's Financial Resiliency, the Open Minds Approach to Nonprofit Financial Strength Assessment. You can find that under www.openminds.com, listed as webinars under the events tab. Thanks again, Sharon.
Thank you. Bye, everyone.